Hi, Mohammed Tawfiq. Did I choose the right music? Do you think that music was played well? I don't know whether this is the. So, may I display your presentation? It's all right that I share the presentation right now for you. Just a second. Can you hear the sound? Is the sound playing well?
We have a problem for as you can see here, this is the pictures when the patient is coming from underground after 8 days of bombing his house. And this is the pictures in OR, and this is a picture of a plastic surgery he's doing. And he's coming for me for after reaching these situations. His right eye is lost and left eye with intraocular foreign body and cornea, intraocular foreign body and retinal detachment, closed funnel, BVR. And he asking me for a hope for being saying again. And as you can see, his brain just before going in the surgery. But unfortunately, we found this a big intraocular foreign body impending over the disc with a very closed BVR retinal detachment, and we cannot able to bring him back for vision. And this is a child with a situation that he in Gaza Strip he's usually using the canned food, but actually there is an unreleased bomb like a canned food, and this child is mistaking from this type of canned food and the unreleased bomb, and he's able to open it, and he's bombed it over his head, over his hand and eye, have a ruptured globe and lost his left right fingers. And we did it much more like this from children. And also this is a bombing of house for this child who is going to lose his total eye because the bombing is affecting the face, and the eye is exposed by the optic nerve outside the eye. And this is a post-operative situation of this child just 10 days after surgery, and how can feel the tear of this child is affecting me. And also you can see that the left eye, his left globe is lost in the eye completely. This is also the case of empty socket, total empty socket, and the right orbit is totally empty, and we are connected, the right orbit is connected to the left orbit and connected to the brain. So with the help of our plastic surgeon, Dr. Adam, is doing like a flap to close the gap to prevent the progression of any organism or also the infection. So he's just trying to close this defect. And by the way, the patient in left eye, he's seeing 18, so he have a perfect vision in left eye. So by help of Dr. Adam, we are able to do the flap surgery, as you can see, and closing the gap, hoping for the better reconstructions of such a type of trauma. And this is also the patient, a single-eyed patient. He came for retinal detachment, intraocular foreign body, and hand motion vision, and how you can feel the tear of this patient when he's starting to see and when he's starting to feel that the vision is coming back, coming back. And also I need to thank the custom surgical, because as you can see, it was very helpful to document all this surgery, and also very helpful for helping with my colleague in the OR to sharing the knowledge and experience together, and also the documentations of what we are doing. And finally, at 21 May, we finish our mission in the European Gaza Hospital, going back through the Jordan because the Rafah crossing is closed. But unfortunately, 1 month later, the European Gaza Hospital is invaded, and we are not able to work again in this hospital. As you can see, the doctors is trying to remove the machine from the hospital, put it in a safe house until we going back to the surgery, until we going back to this hospital. So until now, 1 month ago, we are going back to the point that there is no any OR room for ophthalmology surgery, so we are not able to do any vitrectomy cases, cataract cases, anything until now, just a trauma cases. So we are need to put a highlighting for this situation. And thank you for everyone.
This is great, and we know the difficulties by watching your video that we get from, you know, all the possibilities of trying to do the best, and of course you cannot do elective surgeries, you gotta do emergency surgeries, but you do that well. I was seeing those intraocular foreign bodies, very strange, like big stones, you know, inside the eye. So this is very difficult to deal with. And congratulations. And which were the most difficulties you faced when getting to Gaza in terms of doing the setup for surgery? Of course, you've got the materials, you've got the camera, the mobile to with the program to record surgeries. But what do you think? The price of everything, and seeing those patients happy because they are trying to get back vision. And so, how do you feel? What were the most difficulties you found, Mohammed?
I can tell you the true from the starting the preparation for the visit. When I see the microscope at the starting of the thinking about the mission, I would have read about the surgery because when I see such a type of microscope and now we are working in a 3D model for a surgery, I feel that I am not able to do the surgery. And also, I don't have any idea about the machine that I get it with me to the Gaza Strip. It's an Opticon portable phaco machine, phaco machine. I have no idea about this machine. I never used it before. And also the scrub nurse. The scrub nurse is never do any vitrectomy surgery before. So all this is challenging is connected together. And by the way, I need to train by the company how to set up the machine because I get the machine and also I am responsible to set up the machine, connected the machine and open the machine. And this is what I'm never doing before. So all these situations is challenging for me. But believe me, I have no idea how it's going well. Since I'm going back from this mission, I have no single idea how it's going. How the scrub nurse, just 2 days after surgery, being able to work with me, being able to starting the case, starting the setup before I'm going to R. I'm not have any idea how come just I open the machine. By the way, if you are seeing that I transferred the machines and endo laser in a traveling cases, traveling back. And as you can see, when you move the laser machine from the OR room to the other OR room, it's able to broke, it's able to lose something. I traveling with a bag inside endo laser, 400 kilometers, 12 hours moving. And when I reach the hospital, I 99% thinking that this laser machine will not work. It's worked very well. And this is also what's happening. I have no any idea how it's going, but believe me, it's going very smoothly. 125 vitrectomy cases in 20 days. You can imagine how it's working. It's for me, it's not thinking, it's not thinkable to back do what we are doing again. But it's done. It's done. And but the situation now, it's now more worse because this hospital was the only hospital that have an ophthalmology room, and this hospital is out of service now because it's invaded again. And we are back to the 0 point because 1 month from 1 month until now there is no able to work again in the hospital.
Congratulations, Athanasius. What do you think about this great work? I feel emotion
I
because
think that I believe that Nataraja has shown us so many injuries from Kashmir when he was at the war there. And you never hope that you're going to see it again happening. But the Gaza situation is something unforgivable to anyone for any reason. For me, it's the humanitarian disaster of the human race. And I think when I told that Mohammed is doing something for all of us, he's doing something for all of us. Would never think of some young surgeon who is very capable of doing so many things in his life and carry on with himself. He would go in the middle of a war like that to serve other people. Situations like that are make you think that we are unforgettable, not the other. We are unforgettable. and your abilities to help people is what we are there to serve. Doctors are to serve, nothing to do with ideology or who is behind the table or who is doing surgery. The issues are that you need to know everything from yourself, from the laser instrument, from the microscope, from everything. You cannot depend on the nurse, on the scrub nurse, on anybody else. You have to depend only to yourself. And I think the most easy task to do, I remember they told us during a crisis in Greece, they told me that I have no microscope. And I was using indirect ophthalmoscope to do vitrectomy. And Nati knows how to do it with indirect ophthalmoscope, because sometimes the microscope is not working, nothing is working, and just have a machine and an indirect ophthalmoscope. So I would like to know what the Nataraja is thinking about, because he have lived the war. I don't know, similar to that. It cannot be similar to that, but it was a war. And
Yes. So I know, Thanasis, thank you. I know I was in tears when I saw what all Dr. Taufik did. I think hats off to you, Taufik, on behalf of all the eye surgeons of the world, because I think when there was a call from Kashmir, it was just through a WhatsApp saying that they already had 25 eye surgeons in the medical college, and there was a problem between the civil hospital, that's the medical college of government, and the army. They were not allowed to talk for whatever reason. And plus the ophthalmology department was isolated. So there are a lot of press people pressurizing the eye surgeons, asking why this and why that, which I think Dr. Tariq Qureshi, he was the head of the department. He was a well-trained retina surgeon, but I'm sure he was shattered with all the questions from all over the Middle East to the all over India and even New York Times. Everybody was questioning him. And that is the time they called me, and I think not called me, they sent a message. And I think I was the first one to say on a Sunday in a CME sitting in Patna. It's about 2.5 hours from Mumbai. So Sunday, I went with the Borderless World Foundation with an NGO, surprisingly from Pune, which is 200 miles from my Mumbai. They were doing camps regularly in Kashmir, and they took me, not the government, not the any other person. So I just went. When I went, it was shocking because it was like a deserted, haunted city. Everything was closed, all shutters down, no lights in the street. And suddenly, I think there were militants who were coming and throwing stones at the police, and police were shooting the what do you call the this one, not pellets, and that was the lead pellets which they were using. And so I think they were doing surgery, but the problem was 150 injuries were coming at a time, and that can be any time of the day. 25 eye surgeons were doing the primary repair. Sometimes it happens at 3 in the evening, and the surgery, eye repair goes on till the next morning. So I was there 5 days a month, like that for 5 months. And when I was operating, they gave me, because they had one microscope. Fortunately, his eyes could help me get the biome, and we didn't have 3D, but I had the biome, not the biome, the rise. What wide angle came on the biome. The I also had and finally took biome later in the third trip, but I used the biome. They had the good microscope, luckily, and I suggested we should improve the department. So I used to operate from morning 7 till night 11, and I actually developed a cervical spondylitis. And then finally, I did some physiotherapy to get, because I have designed a hand rest in my OT, but there, as you Taufik saw, but fortunately we had a recording system, so I have 1 TB of recording and everything. But it's sad to see that, I mean, there were multiple hundreds of people at a time injured, and then all sorts of injury, whole body, whole face. I mean, it looks very sad, but I don't know, somehow I had that guts that nothing will happen to me. And whenever later when ambulance with some doctor goes, if they tell it's Dr. Natarajan's mission, even I mean, either the police or the army or the militants, all will give way. So I think I didn't have any problem. I answered all the press, and I always told them I feel like working in a I keep seeing the movies of World War with the Red Cross. The doctors and nurses worked in the Second World War. And I said, we are like doctors, why question us about the differences happening in the government, public and other things? So let me do my work, and whether they will see or not, it's in the hands of. And at that time, the name of the medical college was Maharaja Hari Singh Hospital, and my name, Natarajan. We have the two Hindu names. Rest, the patients, the doctors, and the medical, everybody. I mean, Kashmir has a lot of Muslims, so including almost, I think 99% of the patients were Muslim, but that didn't make a difference to me. But everybody's blood is same. So I hope, I think the world will get peace. No more things should happen like this. And even when Ukraine happened, I told them, I told Dr. Robert Redak from Lublin, because I used to go there, and then I offered my services. I think the doctors were known to me from Ukraine. I've shifted to Poland or somewhere to work now, and it's a sad state. And I think, and I hope, fortunately, right now, Kashmir is in peace, and I hope I have suggested to the government, make us a northern part of the country the center of excellence for vitreoretinal surgery, and also manage trauma, because beyond Delhi, there's a good institute. I hope they can develop it better.
Thanks for your comments, Natarajan. I know that they are very welcome. And I see here YL, we used to discuss some cases in the WhatsApp chat, like vitreoretinal cases. And YL is also from Egypt. YL, are you around? Do you want to make any comment from Taufik's presentation? And I want to say hello to Dr. Professor Wai-Chin Lam, my professor. How is it going?
Good morning. It's good. Sorry, joining a little late.
No problem. And Li King is there too, and I'm so happy that she brought some residents and fellows from her service, and she's going to be the next presenter, Li King, because you said you are a little advanced in your time, and so how is it going? How is your residency and fellowship work doing around you?
Yes.
Yes, it's very good. So can you hear me?
Yeah.
Can you hear me?
Clear.
Yeah. It's very good. Yes. I just came back from London and touching the Great Ormond Street for pediatric retina. Yeah.
This is cool.
Yeah.
I was watching at the Olympics. The Hong Kong team is very strong. I saw China, Hong Kong, and Dr. Wai-Chin Lam likes swimming. So I sent you a photograph from the swimming competition early this morning. I don't know what time. It's probably early for you. And
Yes.
I know.
It's 6:30. I think, yeah, you're right. I think the Hong Kong team, the women's swimmer, are quite competitive. So they're looking forward to the opportunity there.
all right. Li King, do you want to present your case? Do you have it handy?
Yes.
Dr. Quingley, 1 second. I think where is Taufik? 1 second only. Sorry, Hudson, for Taufik.
I'm here.
No, I know. I wanted you to see. I had a tough time publishing the work done in the Kashmir. It took 5 years for me. I don't know why. Many journals rejected it, and then some lines were even asked me to change, which I didn't want to change. But I finally modified and put it and conveyed the truth. I told them I'm writing the truth. So I suggest you should publish, and I know it's going to be tough.
I already make like an Excel sheet for all the details
Right,
of
exactly.
all 125 cases with the pre-operative, post-operative, everything. But
I know, I think it should take
you're
some
able
help
to
from.
help us for
Yes, no,
publishing.
100%. That's the reason I wanted to say that, because it's not. I think the problem with the publishing also, people are wondering, we are talking something about the things happening, but here when something happens, somebody has to repair it. That's what I took help from Ferenc and even our ophthalmic trauma society. But I think I will definitely assist you, and it's a tough job. We should get it in the peer-reviewed journal so that everybody reads the repair. And I sometimes some politics comes into that, which is this particular platform is where I can talk without any thinking, in the sense we are talking openly. We should publish, and I just want to publicly tell I'll help you. And whatever, not a help, I think it's more than help. Is the publishing will be to salute your work. And I think every young eye doctor should, or rather a young doctor should know how people like you are really sacrificing your time, money, and everything. I mean, a lot of things. I mean, emotionally, it drains you. I mean, just watching this, my heart is bleeding. So I think, I know there are a lot of good people in the world, and that's why we're all together. Thank you, Hudson, for making
Thank you.
topic.
I want to welcome Oshima. Hi, Oshima.
Yeah.
How's it going?
Hi, Yusuke. Sorry, madam. Sorry, Dr. Pingley, for interrupting.
Sorry to be late.
So did you just
Glad to see you
arrive?
all.
Did you do a good move?
Yeah. Just arrived the hotel in Tokyo.
All right. Jorge Rocha, we should get a publication from Mohammed Tawfiq into our international journal, because this is great what he's been doing, you know?
Yes.
Yes, for sure. What I can say, when I see this, I can see the worst part of the human being, that's the war, and the best part of the human being, compassion. Yes. He was willing to break the barrier and help a lot of people with no other interest, but only to help your brother and sisters that are surfing.
Yes.
Thank you so much, and you did a lot, and I think your example, you're gonna have more and more people doing something like this, but you did something very meaningful. Thank you so much.
Thank you. And Dr. Professor Licking, you are welcome to present your case. And I think after your case, I'm going to proceed with Dr. Professor Yuzuki Oshima due to his time. You know, so Licking, you are welcome to Retinawesome 23rd.
Yes. Can I present it later? I cannot share the screen. I have to leave the meeting, and can I present the next one?
Okay.
Oh, yes.
So
yeah, now it's
authorized.
okay.
Yeah.
Let me share. Yeah. Okay. Can you see the screen?
Sure. Yeah, it's all right.
Yes. Okay. So I thank you for inviting me to join the Retinawesome today. And I would like to show my respect to all the medical staff and Dr. Mohammed in the work in the Gaza, and the work will be tough, and you have done a lot for the local people. So today I would like to share my current usual practice in tackling the diabetic attractional retinal detachment. This is a 50-year-old lady who is a refugee in Hong Kong, and she had been suffering from diabetes with poor control, and she had already had the attractional detachment for 2 years. So after this is the video demonstrate the operation in the vitrectomy. After the phaco emulsification, the pupil is very small and like 3 mm pupil and all along the surgery. So I first do the core vitrectomy and remove the vitreous above, and then I just use the switching between the iron forceps and the cutter to remove the membrane in the posterior pole. There is a flat membrane over the all posterior pole, and I found that the cutter and iron forceps can tackle all the membrane in the attractional detachment. I use the iron forceps to elevate a bit of the membrane and find the space between the membrane and the retina, and use the cutter to delaminate the membrane. And I think the Count-size microscope is very good for tackling the tracheotomy in such a small pupil. And for the local traction, I will leave it for the tiny traction and cut the membrane over the local traction. And for the this kind of traction, I found that there is a less adherent membrane over the mid-periphery. So I usually use the iron forceps to elevate the mid-periphery ridges and to remove it from the retinal surface with caution, not to create any iatrogenic break. And then use the cutter to cut above the membrane and cut it smaller. And then afterwards, we can find the potential space between the membrane and the retina, and then cut the membrane smaller in smaller pieces. And I don't usually use the Witch's scissor to cut the membrane, but I use the scissor to identify the potential space between the membrane and the retina. Like in this membrane, it's very adherent over the vessel, and then I use the scissor to undermine the membrane to find the space, and then use the cutter to cut through the membrane. But in this maneuver, it won't cause any iatrogenic break over the retina. And I don't inject anti-VEGF before the operation because the breathing will be controlled by elevating the pressure and also by the laser coagulation. So after the membrane removal, I will use the focal laser over the breathing points, and also do the barrier lasers around the focal traction, the remaining focal traction, and then do the shaving vitrectomy over the mid-periphery, and then remove the blood clots by the soft tube, and use the gas tamponade. This is the patient 2 weeks afterwards. The retina remains flat, but the photo is very poor quality because of the small pupil. Okay, thank you. That's the end of the presentation.
Good case. This is, oh yeah. Doctor.
I just want to comment. I was involved with Lei Ching during this case, and I think she showed remarkable dexterity in just using a single-handed maneuver to dissect a very complicated tractional retinal detachment with almost a tabletop kind of fibrous membrane that cover the disc and the macula. And just want to mention a couple of points that are useful when people approached this type of membrane, and using what Dr. Lee was doing is that when you remove the membrane, I don't know you notice it, you do the you put the cutter from the inside of the membrane, and then drag the and using the aspiration and draw the membrane towards the cutter. This way, you can minimize the risk of cutting a hole in the retina. If you have an outside approach to the edges of the retinal, the pre-retinal membrane, as you draw the membrane, you might draw the retina as well. So I'll say it one more time. So if you have a piece of membrane that you isolated and you want to remove, and if you bring the cutter put it inside the membrane and draw the membrane towards the cutter from inside rather than from the outside edges, and that will reduce the risk of creating a retinal break. And secondly, using endo laser to do the coagulations of the vessels or bleeding point is also a good technique, because using a diathermy often it coagulates the tissues, and it also sticks to your diathermy, and that will sometimes create an iatrogenic break, and that is not an ideal situation when you were operating on a diabetic. So using a endo laser, with the blood bleeding, and you can coagulate easily. So those are little points that can help to minimize any complications.
Yeah, Natarajan, you wanna talk?
No, I just want to know, since the pupil was small, what was the observation system you used? The biome or
I used the cow size biome, the yellow lens. I forget the doctor. It's the yellow one, the cow size. I think it's just
Okay.
remove the microscope to focus on the points that it will still give you a good view for the maneuver. Yeah.
Okay.
So
Yes, I know.
she used the resight system.
Resight. Yes, that's right. Good, because I think when the pupil is small, you can still, with the wide angle, you'll be able to see. I know you had difficulty, but the only problem is you have to follow that single line for the focus. So you go a little away, then you will miss the image. But good,
Yeah.
excellent surgery. Thank you.
Thank you very much. I was listening to Dr. Lam, and my case that I'm gonna present is on diabetic retinopathy, and I follow strictly those advices because sometimes I get a membrane, and sometimes I cannot just keep pulling the membrane, otherwise I will cause a break or a peripheral break or a break around. I follow the steps from, if you have the macula free, and of course you don't want to create any break at the macula site. So I usually peel from out towards the macula, and also I use the cutter right at the membrane when you cannot pull it forcefully anymore, when the membrane cannot reach wherever you want to detach the membranes from the retina. So I usually like using the cutter, the 23 and the 25 gauge better. They are very special tools for doing a good vitrectomy for diabetic retinopathy. And I followed those advices very strictly, and they work well. Thanks, Dr. Lem, also for your advice on that. Also, next to speak is Dr. Professor Yuzuki Oshima. Dr. Oshima, I have your presentation here handy.
Can I share my my slides? You let me to control?
Sure. Do you want to show them directly, or do you want me to show?
Yeah. Can you let me to share my slides from my from my side?
Sure, of course.
Thank you for inviting me this time. Almost 1 year after last time. Yeah.
So let me just make you a co-host over here.
Yeah.
Yeah.
Because that's okay.
That's
All right.
okay.
Let me to share my slide like this one. Okay. So can you see my slides?
Yeah, it's not on full screen yet, but I see them.
Yeah, full screen?
Yeah, it's now, okay.
Just wait a moment to let me check. So can I see my slides, okay?
Okay now.
All right, so I just give you one concept about membrane removal. Just last presentation showed a very challenging case. You used a very nice skill to remove the membrane with the 25 gauge. So right, I just show you my concept about the how much you need to remove the membrane during the surgery. So here I show you the fibroblast membrane in diabetic retinopathy is very challenging. So the situation need to remove the membrane. Sometimes the encounters to make the new breaks, or during the surgery, also during the manipulation, you may encounter some bleeding from the retrovastature, or encounter some iatrogenic hole. So makes a much challenging situation because of the advancement of the attachment during surgery. So even though we have so many very nice helpful skill and instrument, just like the scissors, forceps, and the very nice cutter, and one view system and chandelier, just like show in the last presentation. But still, we encounter some complication in the surgery. So I think about why I need to remove all the membrane, especially several cases, just like the this case. as a membrane and traction attachment. After remove the membrane, we still sometimes encountering some complication after surgery, just like the neovascular glaucoma. Otherwise, just like this case, the separate charging membrane, we can use a very helpful skill and instrument to remove the membrane with the gas tamponade to attach the retina, but finally encounter some atrophy of the optic nerve, and finally we have reduced visual acuity. So recently my colleague reported about even the neovasculature, you have some anastomosis to supply the normal circulation. The reason why we need to remove all the membrane, because sometimes the neovascular membrane sometimes it may be helpful to keep the homeostasis of the retina. So for like, it's not every case we can do this, but just like this case, without any breaks, the only fiber membrane mainly fractured macula. So this case, I tried to only remove the membrane, release the traction around the macular area, because this is a case with the last only thin eye with this patient. So I just like showing the video, I just gently use the single hand to remove the membrane around the arcade area and try to release the traction to the possible. So you can use the cutter to separate the membrane. Can you see the video?
Yes.
Can you see the video? Okay.
Yes.
So I don't remove all the membrane too far peripheral area, because this case I'll show here that PVD not occurred. If we remove the membrane as much as possible, of course it can do, but sometimes maybe encountering some region breaks. Once make the breaks, in this case, if we encounter the joint attachment or something. So for example, this case, I mainly focus on how to remove the traction around the posterior area. I also perform iron peeling, remove the membrane around macula, and don't care about any nasal side. I just release the AP traction, and main focus is to perform the laser to peripheral area, and remove, I still remain the membrane at the nasal side as show this case, because this case I did not create any new breaks, any breaks. So this case you can see even 3 months after surgery, they're not a severe contraction because the mature membrane has less contraction power, so you can leave it as it is. And you can see the first angiography before the surgery, and you can see the prominent leakage from the arcade neovasculature after around the arcade area. But after surgery, you can see even the late phase, a little bit of leakage from the neovasculature, but actually it's not so bad, and still keep the visual acuity to the 20/60. Another case shown here, this is also a case where it's also only thin eye, and I removed the vitreous hemorrhage and releasing AP traction. I still remember a prominent membrane around the arcade area, but actually here you can see I release the traction, contraction that is around the arcade area. So just actually in this video, you can see initially I use the vitreous cutter to remove the AP traction, and you can see a very ischemic retina without the laser. So my main purpose to this patient is to use single hand to release membrane traction, and just like shown here, of course, it may be 25 or 27 much better to insert between the membrane and the retina. And also as you check the peripheral area to any other breaks, and mainly to remove the releasing the AP traction. And because the temporal side, sometimes the contraction may be much severe. So I also cutting off the interaction between the upper and inferior arcade membrane. And then you can see I still remain a long, prominent membrane there, but my main purpose is to perform the laser and let the interaction, contraction each other. And finally, you can see this case is through the angiography. Before the surgery, very severe ischemia retina, and but after surgery, the early phase is not so bad, and this is the late phase. Also, still have some leakage from the neovasculature, but it's it's not so prominent, and sometimes it's very stable. So the video, this is the photograph. You can see even 6 months after surgery, the contractions remain as it is. And we can still preserve the macular formation with keep the visual acuity 20/50. So the key point of this case iteration, the surgical tips, the limited membrane dissection is very important. So there's no every case that can be used this strategy, but if the case iteration for the patient with a mature fiber membrane is less contraction, only with tract attachment only, and the case without PBD can create PBD just on the temporal site, we can remain the membrane as it is the nasal side. And especially the ischemia case with the non-perfusion, the main purpose to perform the laser and releasing contraction may be the main purpose of the surgical strategies. The surgical tips is releasing the traction within the vascular arcade area, and releasing the AP traction may be important from the equator to the peripheral if possible. So pump for direct coagulation up to the far peripheral and then complete the hemostatic during the surgery may be the main purpose of these surgical strategies. So the pros and cons of this limited membrane dissection strategy may be the less surgical complication during the surgery, less bleeding, less chance to create breaks, and shortening surgical time with less surgical induced inflammation, and less chance to use a tamponade material. And even this case, maybe with a fluid-filled eye or only air tamponade with no need to any long-acting gas, and the vascular restoration can be expected. A visual restoration can be expected. The cons may be the regional attachment due to the regional membrane contraction. So need to select the mature membrane with less contraction case, and the late onset bleeding may be occurred in this case. But for my case, only the very limited case, but I have not encountered any severe complication in this using these strategies. So even though the several arguments still remained, the concept of limited membrane dissection in the severe PDR case is worth to be considered, especially in the case with only thin eye and or the case with very severe retinal ischemia complication. Thank you for your attention.
Thanks, Dr. Oshima. Great presentation and great images and videos. Dr. Lam, would you like to comment on Dr. Oshima's presentation?
Sure. I think that, as always, Dr. Oshima showed like amazing surgical skill. The 27-gauged instrument nowadays really is a multi-functional instrument. It can work as a forceps, it can work as a cutter, it can also work as an aspirator. So I think it really has revolutionized a single instrument, kind of single-handed approach to tackle this complicated diabetic fibrovascular membrane. And they are usually very difficult cases, and you need to avoid creating any retinal break. I think that Dr. Oshima has showed the kind of very detailed technique of how that can be approached and dissect off. And I really like his point that you don't necessarily have to remove all single membrane. And some of the membrane actually is best to leave alone, because I think when you try aggressively, sometimes we're too obsessive compulsive to try to make the retina looks clean, but that's not the purpose. I think the purpose is to help the patients. It's not just to make it look pretty. I think that avoiding some of the more, like leaving some of the membrane that is not kind of contributing to the problem to the eye is a very wise decisions, but not something that all of us has developed that wisdom like that Dr. Oshima.
Thank you very much for your comment. So because they encountered some very disappointing case, even removed all the membrane, still encountered the glaucoma and encountered some the atrophic optic nerve. So they think about why I need to remove the membrane. Sometimes the nerve vasculature, maybe just like showing in the clinical research in my colleague, even the membrane and the nerve vasculature still have some anastomosis to the normal retina. That means that some of the normal supply is contributed by the nerve vasculature. So they think about it, not all of the nerve aspiration, maybe to perform some of the role. So we can try to remove and to remain some membrane. Just especially the case with very severe ischemia case was the only thing once you encounter complication, you will encounter very disappointing results, So that's why they think that. Of course, the case selection is very important. I'm not established that formal normal guideline, but they think about how to remove that the main member. It may be worth to think about it.
May I ask you something?
Yeah.
Can I? First of all, thank you for giving us a carte blanche that we should not remove everything. The second thing, I can use your SEMA presentation to show that I left some prints because of a SEMA. The second thing is that the worst nightmare is to make a tear in the eye,
Yeah.
especially when it's unnecessary to do it. So
Absolutely.
sometimes the excessive thing that is not doing a purpose, it's something that I avoid all my life. And when I finish up having some vision for the patient without endanger the rest of the operation, I just relax and say, okay, let's save this eye for this, because always there's a second chance. You
Yes,
leave
that's
yourself
right. That's right.
and the patient second chance. That's very important, because if you destroy something on the table, you cannot save it again on a second chance. Then the other thing you do is you do a perfect laser. And you have to remember, for all the people that they are listening to us, there's a circle. Proliferative vitreoretinopathy in diabetic makes a circle. It starts in a new membrane, new things and everything. And even if you leave it, it's going to strangle itself at the end point. So if it's going towards the end point, you just give him back the vision, but you don't go any further, because it's going to deteriorate by itself. By just giving it some laser and take the time, it's going to be healed by itself. So we have to remember, for that circle of retinopathy, that that's why you said mature membranes, and that's why you said that, but it's evolving. So I think it's a very good take-home message, this one, because I don't like live surgeries when people are trying to make it look nice, and you change from one camera to the other when you make a detachment or you make a hole. Because if you make a hole, then the take-home message is you need to relieve all the traction.
All of that. That's right. That's right. Yeah.
So if you make it, you have to finish it. And that's what I want to say, that multiple lessons from the video. And as usual, thank you.
Thank you very much. Thank you very much for comment. Thank you.
Can I ask a question, Dr. Yoshima? I have a 2 point I need to be illustrated for me if I need to change my mind how to deal with the traction retinal detachment. First, is it applicable to keep the fibrovascular membrane connected to the vitreous remaining? So when I starting to leave the fibrovascular membrane, I was intended to make it free from any vitreous attachment. So if the contractions coming from this membrane, after that, there's no connection between the fibrovascular membrane and the vitreous. So the most difficult part to do this is the nasal part. So when I start to dissect the membrane in the nasal, especially in the nasal part, and the vitreous is still there, was difficult for me, and ended usually by doing a break in the nasal part. So it's applicable by your message to leave the nasal fibrovascular membrane, even if it's still connected with the remaining of the vitreous attached?
If we think about the distance, the length from periphery to the optic nerve, the temporal side much longer than nasal side. So my mentor Yasuo Tano always told me, don't care about nasal traction. Don't care about that. The temporal traction may encounter some detachment to the macula, immediately threaten the visual acuity of the macula. But nasal side might be far. And just like I showed in my video, I just make sure how the connecting the vitreous attached to the peripheral retina was that. So just tell you, I use the indentation to remove the traction from peripheral to the nasal membrane. Once we leave that, you don't care about the membrane staying in the nasal side. If we can cut off the contraction, cut the connection to the far peripheral area. So the reason why I just told you, and my last slide showed the key point for this case selection is make sure to leave the AP traction as much as possible. But in the temporal side, you need to remove, you need to cut off releasing the interaction peripheral to to the posture as much as possible. But nasal side, basically, you need to try to do that, but not care about complete to leave it. You still can leave it because it's just the traction detachment. It's not combined with the brakes. Just like as I told you, if you want to make the brakes there, you need to remove all of it. Otherwise, you cannot attach retina. But if the releasing traction, the traction detachment may be attached region gradually if it does a perfect laser. So laser is more important for this case selection.
Okay.
Hudson, can I make a comment as well? It's
Hi, Ahmed.
Yes.
Welcome.
sorry, I had an intraocular foreign body very early in the morning, so
Wow, so tough.
just finished. Yusiki, this is fantastic. This is what I've been doing actually for about nearly 4 or 5 years now. And I think really my analogy for it is ROP surgery. ROP surgery, you do what you can and you stop short of creating breaks, and it works so well. And the risk of, and I think why Shang is here and tell more about this, but the risk of them getting rhegmatogenous retinal detachment, even later on many years, is there, but it's small. And I've not really seen a single case that went on to develop rhegmatogenous detachment because of left traction. I've seen, of course, getting a recurrent post-auto-vitreous cavity hemorrhage for what you've mentioned. I've seen some traction, which maybe I could have relieved more, but I can go back. But the thing is, when I'm not losing eyes, I'm not using silicone oil, and it's really working very well. So what I've been trying is I can remove everything and everything is going fine, then do that. Once I think things are stuck and I'll end up in problems and I've relieved the traction, then I stop. And I think that, in my opinion, it just works fantastic, makes life easy, and I think it's just much better. Silicone oil in diabetic is just really very bad.
Yeah, sure. Yeah, the most challenging case is subsilicone proliferation. In this case, you cannot remove the membrane. So reason why.
Actually, I have a case as well, similar to Ty with your presentation. I was actually going to present on the same as well, but I totally agree. I think this is really very important to consider.
And you can still remain the second chance to remove membrane.
Yeah, absolutely. Yeah, absolutely. And it's just much easier to come back again if you need to. Also, the other thing is many patients have very guarded vision, whatever you do. So you just want to keep them with central vision.
Yeah, that's right.
Doctor.
Especially the only thing I know is
Exactly.
But silicone oil is a tool. Silicone oil is not something you hate about it and you say, I don't like it. It's an ugly thing and all this stuff. Because I've been trained with John Scott. Like Osima was trained with Yasuo Tano. So these are masters. They knew what they were doing. And they always told me that I'm not teaching somebody how to use the silicone oil unless they're willing to stay for a long time with me.
Absolutely.
Because if you use the tool incorrectly, the silicone oil is a bad weapon. It's a knife. You kill the patient with silicone oil. But if you use it only in purposes where you cannot avoid it, and you give time, you buy with silicone oil, also you buy time when you can get a second chance. I always think about the second chance because we're not unbeatable on what we're doing. So if you use it only to buy time, or if you use it as a last resort, and you use the new purified silicone oil 5,700 centistokes, where they don't emulsify so quickly, and you know how to use it, you don't have all these complications that people, that they don't know how to use it, or they inject it all the time, because that's the easy way out. I'll do it and I fix the retina. Anyway, this is the worst kind of silicone oil. And thank you for pointing out that silicone oil is not a good tool for everyone. It's a very specialized tool. And I would like sometime Retina-Awesome to do a section about how to use, to put, when to put, and when to remove silicone oil, and how to remove and how to inject silicone oil. It's a whole system. It's a whole lesson. It's not just an individual thing like gas. Okay, I'll inject gas. It's a different story. It's a different technique. So I just give you an idea that people, they don't know how to use it. And when they use it the wrong way. And that's what we have to tell them when you use it for 35 years now.
I agree completely, Athanasios. And listening to your advice, well, my case that I'm going to present a few moments from now, I have this retinal detachment case, and we are carrying a study on how to use and when to remove silicone oil, because sometimes it helps a lot. And in good outcome patients, I like using the 1000 centistokes silicone oil, and it works well. But of course, in this study that I'm carrying on, we are removing the silicone very early, like 3 months or 4 months at most, especially in patients with clear lens. So it works well, and of course you have to know how to use it, and you cannot just use in every other case, in every case, and of course you have to choose it accordingly. And of course, yeah, we have to create this webinar on silicone oil as well, and the intraocular tamponates. And I remember Dr. Ahmed Salam giving a good advice on how to inject silicone oil and do a direct exchange by using the 23 gauge as opposed to the 25, not to get very high pressure inside the eye in the direct exchange. And so this is a good comment that he made in the, I think, 2 retinosomes from now, and I remember it well. Isn't that, Ahmed?
Yes, correct. It's you can do the passive exchange, and if you mismatch, favoring more aspiration of PFCL, so use 23 gauge while you inject with 25 gauge the oil, that increases the outflow increases the efficiency of the process by 1.5 times. But I totally agree with you, and I think the main point is when to use it, and it's use it only in like difficult cases where gas would not work. So yeah, totally agree.
Yeah, you're right. In my case that I will present before Athanasius, I think I'm gonna put your case right now because it has to be with injection and things. So I will explain you how and why I used silicone oil. But one last question for Dr. Yuzuki Oshima. Dr. Oshima, sometimes you start the vitrectomy, you don't see much of the macula, you don't know how the macula is, and you don't have an OCT because of, you don't get an image because of vitreous opacities and vitreous hemorrhage and everything. So how and when you decide to do ILM-PO with, ILM-PO after brilliant blue, when do you decide in a diabetic patient like you did, like you showed, you doing the ILM-PO?
So, can you hear? So in most of the case, the diabetic case, I try to perform ILM peeling if it's not very severe, complicated with the glaucoma or something, because, some striae, even think they look like it's normal macula, but if you use the 60-degree lens or use the macro magnified lens, you can see just some of the striae on the macula. So I have not clear evidence, but personally, I like to remove the scaffold to prevent lip proliferation. The traditional case, sometimes, just some very strong striae or some the macular deviation during this, you can see during the surgery. Of course, after remove the vitreous hemorrhage, something you can clearly see the macular area. If there's some striae over there, I try to perform the ILM peeling in most of my case. And personally, I have never encountered any severe proliferation on the macular area if you remove the ILM. So I just think that remove the ILM, that means that remove the ILM just to remove together with the epidermal membrane. You can remove the scaffold to prevent the lip proliferation, at least around the macular area. So I try to perform the much as possible, but I have no answer about it's truly good or not for contribute to the visual restoration or something. But for the restore the normal macular retinal morphology, I still try to provide ILM peeling during the surgery.
Yeah, thanks a lot. And
Hudson, I got one more question, please, to Dr. Oshima.
Yes.
Dr. Oshima, since these mature membranes are chronic conditions, what's your experience on the recurrency of neovascularization?
After the case, right here?
Yes.
Basically, just the case, it's fibrotic membrane. It's less contraction. I just cut it off. I have never encountered any severe proliferation of neovasculature later after the surgery. Most of the cases, as I show here, I'm not sure why, but most of the cases, even still remain the membrane there. You can test with the flow angiography to see things. It's no longer so prominent leakage from the neovasculature. I think sometimes it's a regression or record. Of course, sometimes I still need to inject the anti-VEGF sometimes, but not so often actually. But the case selection, I think, is very, very, very important. Just I showed a very severe ischemic case in the mitral membrane. I think that maybe the late stage. It's the late stage of the PDR case. So the reason why I think no longer need to remove all the membrane, because the late stage, the very severe ischemia, just only the saturation supplied by the neovascularization.
Okay, thank you.
Muchas gracias. Noé Rivero, ¿cómo estás? Do you want to make a comment from the case from Dr. Oshima? You have your hand raised. Hi, Noé Rivero, you're around? So before Noé Rivero comments, and I just want to proceed to Dr.
Hello.
Oh, yeah, okay.
Hudson, how are you? Okay. I have two comments. First, the cases presented are very challenged. And I'm really shocked by the clinical case presented by Dr. Mohamed Tafik. For every world, Batman, Superman, or Spider-Man are heroes. For me, who I am Argentinian, Messi is our hero. But today, I have a new hero, who is Dr. Mohamed Tafik, for all he does and he done for those patients. Hopefully, the world will change for the better in the coming years. And the comment of this case present in proliferative retinopathy, with so many tractional membranes, are usually used to cut membranes 25 or 27 gauge caliber, but with double cut, because these vitrectomies act like real scissors with excellent control of retinal traction. To add a tip of this presentation, I prefer to do the vitrectomy with vitreous-based peeling and peripheral photocoagulation first, to ensure a good photocoagulation and to ensure a peripheral retinal in case the retina bleeds a lot in maneuvers to remove this proliferation of this posterior pole. And also to be calm in the post-surgery, because of this patient say the bleed in the post-surgery, and it's leave me very calm to know that we leave the peripheral retina treatment. Congratulations, Hudson, for allowing us to witness this challenge case, and great learning for all. Thank you.
Thank you, Noé. Thank you very much. Athanasius, before, I think I'm going to introduce your case before the case from Natarajan. What do you think? You're ready?
Yes, I'm ready. If you have the case yourself,
yeah,
you can put
I
it
have
on.
it here. So let me share it. Just a second.
It's a giant hair. And you can start it. It's a giant hair, and I just like it to show you that all the traction, it's if you start it, it's at the periphery. It's this is how to remove the traction. There's no traction at the anterior part. To become a giant hair, you need the traction to be at the anterior part. So how you remove the flap? While you're injecting the fluid, the peripheral carbon PFCL, you put another fluid needle on the bimanual way of doing it. You're going to see from the side, there's going to be another fluid needle that is going to create a current of fluid to, you see? A current of fluid that is going to revert the flap. So you have two fluid needles. One is to inject peripheral carbon inside the eye, and the other is to remove to change the direction of the flap. And this is another thing that we have forget that is existing. It's a system that you can put inside an infusion line if you want to inject, and it's done by Med1. and it's an incredible thing that has been forgotten. And you can look how much pressure you can use. You can use 60 psi, 50 psi, and it's not, the infusion line is not getting off. And I don't know why Med1 has stopped promoting this, because you can close it and you put a 60 psi and there's no silicone oil getting outside because it has a double chamber to that. So these are tips and tricks about small things about giant tests. One is how to revert the flap, how to inject perfluorocarbon, and how to inject perfluorocarbon in silicone oil exchange, because this is the best way of doing it, not to go through gas and then change it because you have a slippage problem. You can do it directly by injecting perfluorocarbon with one hand and removing, injecting silicone oil with one hand and removing perfluorocarbon with the other hand, because you have a double foot pedal. Half of it is going to inject silicone oil and half of it is removing PFCL. So this is the trick. Thank you for showing that. It's a very small tip, and I would like to participate in the discussion. Thank you very much.
Thank you, Athanasios.
And sorry for the side. I just wanted to ask you to excuse me, because it's Saturday and it's 40 degrees and it's summer in Greece, and this is Chalkidiki, and this is where I have to suffer now. See, this is the worst possible way of doing a course. And my laptop is getting very, very hot, and I have to suffer for you here in Chalkidiki. So the next time you come to Thessaloniki for the TVRS course, I'm going to send you to Chalkidiki to show it yourself how much suffering has to be done in order to participate in your meeting. Thank you.
Thank you. Athanasios, what is the make of this silicone tip? This is from Med1 or?
It's Med1, and it's a double chamber. If you use your infusion, your normal infusion cannula, as soon as you go over 30 millimeters of pressure, you're going to pop out, because silicone oil, if you know what you're doing, it's lubricating the metals. So it's going to be detached. So you cannot inject through infusion line any silicone oil if you want to use by manual surgery. But with this Med1, that I don't know if they still use it, they have a double chamber. So as you inject silicone oil, it grasps one chamber, it's grasped the trocar into the first chamber. And from the other side, it's a double bore thing. And from the other side, you get silicone oil. And the silicone oil that I show you injecting by 60 psi, it's getting through a tip of 25 gauge without being detached from the cannula. It's an incredible system that I don't know why they don't use anymore, but I think it's existing and it's Med1. So if you just give it a boost or an asking Med1 if they still have it, I'm still having it. It's just a tip.
All right. Noé, you want to comment? You have your hand raised. Want to comment this case?
No, I think the chip who present for inject silicone oil is very good. And in this year in ESRS, I go to Med1 to try to buy this element because I think it's very useful.
Okay. All right then. Natarajan, want to show and display your video now?
Okay, I can.
Do you want me to display it for you?
I can play.
Okay.
Full screen?
Yeah, it's not full screen yet. Yeah, now it is. Yeah.
From a case, a 38-year-old female came with a history of injury, actually while using a gun to push away the monkeys in Agra. And she had a globe rupture with a repair done elsewhere in Agra and came. So I did already the some part of the wound was repaired. So that was in the, well, you can see some material in which the suture was done. So I was dissected very carefully and made a, tagged the muscle and made a 240 band, which went all around except that quadrant where the scleral rupture had been sutured. I left, I didn't make any suture or a belt buckle. I left that. So you can see that's the place where I inspect that area where the wound repair was done. So I'm using a traction suture apart from the bridle suture of the muscle. So now I make a scleral flap for making passing the 240 band, which goes all around. And the other quadrants where the sclera was intact, I made the flaps. Here it goes beneath the muscle, but not, and there's no scleral flap was made in this quadrant. I only make sure that the scleral, whatever suture was done is intact. This is the other quadrant, finally making the flap. So it's totally a sutureless buckle. So here I'm now putting the Vatsky sleeve and moderately tightening it. And you can see after that, I made a 3/4 pars plana entry, and then the infusion is going on, and then you can see the total retinal detachment. I'm using the perfluorocarbon liquid and reattach the retina, and you can see the buckle effect. So there's already the silicone oil there, and I'm actually removing the last part of the PFCL and then moderately tightening more so that there's a buckle effect. And so at conclusion, I actually gave some intravitreal, we saw the 1 drop of 0.1 tricot, and then this is the picture which you can see a 360-degree attached retina, and the vision improved from perception of light to 6/60. So thanks to my team for editing it. Thank you.
Thank you, Natarajan. Such interesting case and traumatic, and I saw this case has some opacity, corneal opacity. Do you, to approach retina, how often you script the cornea to get into the eye? And but this case, you just stuck with more of the peripheral and the buccal thing.
Yes, and because of using either the biome or the recite from Zeiss, and it uses using the narrow beam principle. So many times I don't do anything, touch the cornea at all, and that's why I sometimes, if the bimanual dissection required, I use from the beginning the what is that, chandelier elimination, so that I can use both hands and do the surgery as quick as possible. So if you do the surgery quickly and not use any ringer actate to wet the cornea and use only the visco, many times I don't touch the cornea, and particularly in diabetics, because diabetics, they may not heal well, and even in trauma, there can be a risk of a corneal problem. So I think for a long time, I have not removed corneal epithelium, or even if there is opacity, I don't really touch the cornea part, because and if it is a very bad, then I do plan a temporary keratoprosthesis where if you cannot see at all, and then do a penetrating preserved cornea. And if required, if you get a fresh cornea, I do a penetrating keratoplasty with the help of the cornea surgeon. But I don't like to touch the epithelium at all.
Yeah,
that's a great tip, not to touch the epithelium, because in those wooden eyes, the covering of the epithelium and the healing of the epithelium takes months, and good home take. I just like to mention one thing. We used to have Cesare Forlini as our brother, the late Cesare, who did a course on trauma cases in Retina.
Yes.
And we had this beautiful trauma course. How do you learn how do you teach people how to do traumas? I mean, is there a lesson? Is there in a fellowship? Do you have people that they get traumatized and you give them to fellows? The most difficult thing is to teach how to do a trauma. Most of us have been trained by cases, not by somebody who taught us how to do, like Ferenc Kuhn and Ataraja, who tell us how to do the steps to trauma cases. So from Uretina, they have removed the trauma course completely because it's not interested by companies, because you don't spend money in doing trauma cases. So the only one that we have a course for trauma cases, and you don't see any courses for trauma cases anymore after Cesare Follini. And it's a very bad issue because nobody knows a few steps that have to be vital. For example, they put buckles in trauma cases before they know what's going on. And with the buckle, they just destroy the eye. Proliferative, whatever they're doing. So I need your support on that we have to fight to do a trauma course in Uretina or ASRS or something like that, and to have some courses on a fellowship that they are attributed. Ask Ferenc Kuhn to give us the book and to have 1, 2, 3 steps for trauma cases. You never, chorioretinectomy is something we learned from Ferenc, that if you have a foreign body in the eye, you should remove the retina above it and the choroid together if you don't want to do reproliferation. How many people don't know that you have to remove the choroid of a foreign body in the retina in order not to have reproliferation? And I'm asking everybody his opinion on that. I mean, this is very important. There's no teaching anymore on trauma cases.
Yeah. So I know Therasis, and still I'm part of actively the International Society of Ocular Trauma and President of Asia Pacific. So fortunately, in the World Ophthalmology Congress, we have 6 sessions on ophthalmic trauma for the last 6 years, because from Ferenc, I took over and I'm involving Ferenc and Arne Vicenters for including the trauma courses. And George is there from Retina World Congress, but somehow I didn't make a voice, and that's my mistake. Maybe this time I'll request George and our Barry to include that in the Retina World Congress. I know it doesn't bring money, but same way we are happy that American Society they have changed their name, and Ferenc Kuhn is a founder now, where it's called American Society for Ophthalmic Trauma, and they have a special award for trauma work, and it's called the Ferenc Kuhn Award. And so I agree with you. I was part of the Cesare Forlini's high school trauma, which he was really doing it very well. And unfortunately, it stopped. And I also tried sending courses, but we did not fight. I know we are upset about that, but I think we have to do some advocacy. This is what I learned from the American Academy of Ophthalmology. So we have to find a way to influence our own colleagues to include. So American Academy also does not have a separate for the free papers also on ophthalmic trauma. So then they told that if you have more free papers, then they may include as a trauma course. We had about a few years back. Again, it is rejected last 2 years. But we have to be perseverant and persistent. And I think it's a very good point where the fellows who work under us directly learn ophthalmic trauma repair, because by watching what to do and what not to do. And then, but if you don't teach them the important meetings, I think that unfortunately, trauma is not only war, trauma is in domestic, sports, in industry, road traffic accident, or even I recently operated a very, very tough injury. 2 children were playing in the school and they just heads clashed each other and the glass broke and the things inside of the eye came off. And then I had to do the wound repair, and then finally I did a secondary repair within 100 hours, which me and Ferenc are trying to promote all over the world. And then the second surgery, they wanted to go to Boston, and they were all writing back saying, why do you want to come to us? And Natarajan does, or Nati does more trauma surgery. But anyhow, the patient wanted to go because they were US citizen. And then even Dean Elliott operated, and he was telling, it's a terrible eye, and I don't know how you did it. Ferenc Kuhn also shared so I think trauma experience is a problem in many places, but we don't want trauma. But I am creating as a tertiary care center in Mumbai. So I keep telling, do the wound repair as quick as possible and send the patient in 2-3 days, wherever from within India, to some tertiary care, so that the repair should be done by the most experienced surgeon, because not only saving the eyeball is important, but restoring the vision should be the aim of all of us. So one is prevention, second is teaching because the young people, and I'm happy RNA Centers does 6 days course on wet lab every year, so I'm part of that. This year, first 3 days are overlapping with News.Retinawesome. That's on anterior segment, fortunately. And 3 days are posterior segmented. They are doing a trauma. I'm sure, Thanasis, you also during your course, I know some of the visiting faculty teaches about trauma. So I think every time the trauma, I always told the trauma books are written after the trauma has happened. And trauma repair also has been, so every time it's like a war field. Every time it's a lesson for us, because I also had a case where the explosive happened while I was repairing, because I repaired in 24 hours. So I think lots of lesson we keep learning even after 40 years of vitreoretinal surgery. But I think it's a good point, Thanasis. We all have to take some responsibility to teach our.
Just one final question. Just one final question.
Yes.
If you're getting a job in a hospital that is on duty, on call, do they ask you what is your experience in trauma surgery before they give you the appointment, the job? No, they don't. So if you somebody, a fellow that is hitting himself with an eye injury, and he has to go to a hospital that's on call, on duty, you don't know who is going to operate you, if he had any experience, but you know, he's a retinal surgeon, he's a cataract surgeon, they have experience on that. But how much experience you need to have? So they don't ask anybody who wants to go to a hospital that's on call. And we have to ask them to put it on the World Congress, that you have to have qualification of trauma surgery because you can't to become on-call surgeon on a hospital. That's a very good point.
Yes, I think we'll work on it. And I'm happy we have an advocacy team both from Dr. Fasika Oreta from Johns Hopkins, our Ferenc Kuhn, then Arne Vicentes. We will work on it, definitely. And surprisingly, I'm not.
The Ferenc Kuhn Prize, give this prize this year to Tafik.
Okay, sure, I think so. We definitely. No, yeah, I'm not in the ASOT, but anyhow, I will tell the current president. I met her in the last year, in the May in Houston. I think the next year the meeting is going to be in May in Houston. I told them not to clash with the Retina World Congress, because I think 9 to 12 is the Retina World Congress in Fort Lauderdale. I requested them to do it a week later. So I think it's a good idea. I think so happened for the last few years, all my presentations are on trauma, because so much of different types of injuries I'm handling. And I think, and many times I tell them, I only want to do complicated patients from all over India, so that I don't want to do the routine. But still, I love to do scleral buckling for a fresh detachment, which I keep doing. And also the wound repair if I'm available in case I'm available in city and in the country.
Don't show your age. Don't show your age. You look young. Don't show your age. Doing buckle surgery means that you're old. So keep it young. Only
yes.
Thanks. Thanks, Athanasios. Thanks, Athanasios, for the comments. And Sasamoto, how are you doing? How is things in Bolivia right now? We have, I think we are 1 hour ahead from you.
Right. In Bolivia, similar to Argentina, with a dollar problem, but we are going through.
Yes.
That's the truth.
So if you want to present your case.
Sure.
What about the wine event you have next year? Another one scheduled?
The name is Winetrectomy. We did one in Tarija, Bolivia. It was with 30 retina specialists from all South America, and it was really a success. We have a lot of fun, a lot of interesting cases, and a lot of wine, obviously. So the next one, 2025, is going to be in Chile, in a place called Santa Cruz de Chile. So you are very well invited. We are with Hudson organized if you want to come, we make the arrangements to you for you to be with us.
What is the day? What are the dates?
220. I believe it's in October or November. We're talking about the dates, but I'll let you know as soon as possible.
Okay, sure.
Nataraja, you're not allowed to take part in more than 500 meetings a year. You're allowed by the government. Okay, so don't ask me. I'm going to sue you.
So the case I'm going to talk about is small procedure for post-vitrectomy, glaucoma. We know the cases that in retina surgery, all the post-op, some of them go to chronic glaucoma, about to 20 or 20% of these patients. So it's important to control the pressure. So we have some mix that can use in those patients. So this procedure called HFDS, and is I use the Oertli machine. The Oertli machine have that HFDS, which is a procedure that help us lower the pressure in those patients who have undergone vitrectomy or post-silicone oil removal, or those diabetic patients that we can control. And they are with a moderate glaucoma, no need to put a tube shunt, but need to control the pressure. So this is a type of mix, the HFDS. The name is high frequency deep sclerotomy. I believe Athanasius know about this tip. And this technique I will show you help us in those patients who underwent to vitrectomy. So let me show you the video. So it's this is a combined surgery. Sometimes I want to show you the surgery to show you how it works. This mix is a really simple procedure. We use the trabecular meshwork to actually lowering the pressure, creating sclerotomy sites. No, so this is a proof that create these sclerotomies to lower depression. It's a beneficial procedure for patients who underwent with elevated IOP. Provider also safe and less invasive alternative to the traditional glaucoma surgeries, like a tube shunt. So what we are doing right now is checking the trabecular meshwork and work with this scleral pathways. So it reduced between 6 or 7 points of IOP, which is okay in those post-vitrectomy patients that need to control the pressure. It's an option that we're working with, and it's not for all patients. It's where open angle glaucoma mostly, and it works very good. And it's, like I said, a different option to control the IOP in our patients, our retina patients. Okay, thank you.
How do you create these sclerotomies to relieve the pressure, Sasamoto?
With a high frequency tip. It's a small tip that you use using high frequency. There's no any complications, sometimes small bleedings, but It's a very simple procedure with the Wortley machine.
Okay, Wetty machine
Congratulations.
is very good. You know, the cuts and the lines, they make things less expensive. We've been testing these earthy machines over here as well, but we are still holding on with the Stellaris and the Constellation. But earthy is really cool.
And the thing is, it comes with the machine, so there's no additional cost for the patient. Like other mix.
I have the benefit of this year TVRS Thessaloniki with Retina Summer School that we did in July to have Marisa Williamson from South Africa, who's a glaucoma surgeon. And he came and showed us together with a biome, the gonio biome lens, which is an exceptionally good lens for doing any gonio system. Can you hear me or am I lost?
We can hear you, yes.
Okay, and this Marisa Williamson, who is the head of the Glaucoma Society in South Africa, they came out with Earthly South Africa. There's a different part of Earthly in South Africa. They came all together with a machine, and also we have the Oculus Bio Gonio lens, and they have an exhibition, and they showed us exactly the same result like you. More than 30-35% of vitrectomy patients have developing late onset of glaucoma. We didn't know that. As a retina surgeons, we think that everything is okay because they go to another doctor, they don't come to us again. So I'm fully agreeing with you that we have to take care of the late eyes with the high pressure because of the vitrectomy patients do have that. So we have also the gonio biome gonio lens that I don't know if a lot of people know that it can be used with a biome system. And it's incredible. I'm just giving you as an information from the latest happening. And you are exactly, the 35% is exactly what we have also from South Africa.
Thank you. It's a very interesting tip that you're giving me because I have a biome. I'm going to ask to have one of those.
Well, it's very cheap. It's single use. But when they say single use in Germany, it's multiple use in Greece. You know that. Because the lens is clear, is sit on a biome setting, and you don't need anything except the inverter that you have already in your microscope. So it's very cheap to use it. And it's beautiful. The gonio is beautiful. You can see everything in the gonio, and you don't have to change things.
Oh, thank you, Thanasis, for the tip.
Thanks. Jorge Rocha, do you have any comments for Sasamoto?
Sorry, I was talk with a patient here. I missed your talk. Sorry.
No problem. So last but not least, on my list, I don't know whether Dr. Lam, did you bring any case, Dr. Lam? Do you want to discuss my case now?
You go ahead to do your case.
Yeah, and because, you know, my case is very interesting and has to do with the cases that you commented, Dr. Li King presented, also Dr. Oshima presented, and so it's on diabetic retinopathy. And let me display it right now. I don't know whether you have the full screen. You have a full screen?
Yes.
Okay, so let me go on here. So this is challenging case. We've got this 63 years old hand motions patient, a phakic patient with diabetic retinopathy, and we couldn't see the macula at all. You see, everything is so bloody, a very dense vitreous hemorrhage. and how to get to the macula, and so how far should we go? And we are trying to get the image, the good view now, a better view for the from the macula. This was performed in Ingenuity Systems Alcon 3D, and I switched to 2D for just for the editing. And now we start to see the macula over there. I'm removing the epiretinal tissue attached to the hyaloid. As you see here, there is much traction. And now the lens is pretty clear all time. I like doing the surgery with a good visualization system. Now we have the macular lens and we see it very well. So you see the retina is tractional with detachment. And I'm removing these membranes over here and avoiding to pull it very forcefully. And as you gave us this advice, Dr. Lam, I'm just cutting with the cutter right now to relieve the traction and not pulling any further. But one thing is that I like to do is to trim the epiretinal tissue very slowly and trying to relieve here this inferior retinal detachment from this epiretinal tissue and fibrovascular tissue, the membranes. And one thing I like to use in all diabetic patients is the cautery. You mentioned you have to use the cautery, of course, not very much, but I find the right vessels, and of course I want cautery the main arcades. And in this case, another tool for letting the retina attached is the perfluorocarbon liquid doing the pump photocoagulation, and everything is so flat and the lens is so clear. I did not move the tips towards the lens, and I like doing now. This is a 23 gauge system, so I do the direct exchange, and as you see here, the retina gets attached up to the end of the case. So by pouring in silicone oil, 1,000 centistokes, and removing all the PFC, the case is over. And this patient, interestingly, even with silicone oil, because silicone oil, 1,000 centistokes, he was 2,400. And those cases that I select after doing these maneuvers and, of course, choosing the right case, and I did not do much retinotomy, just relieved the fibrous tissue. I tried to be economic. In these cases, I've been selecting those cases that I put silicone oil for removing the silicone oil in 3-4 months time, not much. And so I write their names there, I follow up the patient, and so it's 3 months. After 3 months, let's schedule for no more than 4 months, and then we remove the silicone oil, the outcome gets a lot better. Of course, sometimes when we do not have much of these tractions, as you saw here with membranes, I tend to use only gas, air fluid exchange, and SF6. It's enough, especially for phakics, not to last long. So I put 20% concentration, not to get too much of an expansion. And so they work well as well. But in those cases, like this one, and you did not get to see the macula at all just after vitrectomy, and you saw those detachments. So I like doing silicone oil for those cases. And that's my comment. And adding to your comments, Dr. Lam, your advice from Dr. Lee King's case, what do you think about it?
I think, as you mentioned, the dissections of the fibrovascular membrane has been really well illustrated by both Dr. Nees and Dr. Oshimas and yourself. And I don't usually use silicone oil unless there is a need for the patients to travel in an airplane that may need to be avoiding using the gas, because using silicone oil will commit for another surgery. But for instance, in your case, I think you probably can get away without using the oil because it looks like the membrane was completely dissected and there's no break that was created. And the key for a successful kind of diabetic, complicated diabetic traction rectal detachment is really to segment the membrane and avoiding retinal break. I think those has been mentioned clearly from the previous discussions. So no, I think the case that you have shared done well. Like I said, I try to avoid endodiathermy partly because sometimes the coagulation can be quite severe and it can actually cause break, while the endolaser can be done titrated adequately without having the concern creating a retinal break, while you can achieve coagulations effectively hemostasis.
Yeah. I try to avoid those small breaks, but after pulmonary coagulation, I choose the right vessels not to get any excessive coagulation, of course, and then I do PRP and I surround any suspicious breaks, and that works well. And as I was telling you, I could probably have gone away with that without doing the silicone oil. But if the case is less worse, but this is a little worse, so I decided to do silicone oil. But I don't leave the silicone oil for a long time, and they work well if we don't wait for the long-standing complications of silicone oil, including the lens opacity. So I usually schedule them for they're removing silicone oil in 3-4 months' time, because those patients, most of them, these cases that I've been showing you is from the public system. So sometimes they do not care much of their health, and maybe they are not very well controlled in the glucose levels and things and general health. So that's why sometimes we have to choose whether to do more or less. And of course, you are right. If it was a little less worse, then I would get away with that with only SF6 gas. Jorge Rocha, would like to comment?
Oh yeah, I'd like to comment many things. Today was a special day here. So many outstanding colleagues and many very important tips from everywhere. It's not easy to have Nataranjan and Athanasius together telling you about important things in trauma case. I agree completely. We need to have more course in educations in trauma. It's very few, and I think around the world, the fellowship program sometimes misses this important part. And I really support you guys to do this. I will try to see if next year we can have something in the RWC. Let's see. And welcome to good friends that's here today. Susana Teixeira from Portugal and our friend Fahel from Egypt. He's very good, and it's good to see all these friends here. And about diabetic, yes, diabetic is not easy. Oshima did a great job today telling us that it's very wise not to remove all the fibrovascular tissue. The fibrovascular tissue can help in give oxygen to the retina. Also, sometimes when you try to clean everything, you make a big mistake and can lose the eye. And then sometimes just cut what you need. Less is more. And other thing about diabetic, you have to take care not to operate long time with high pressure. The optic nerve do not resist for a long time. You need to go for 20, less than 25 millimeters mercury. It's more safe because sometimes you have a beautiful case, but we have optic nerve ischemic. And about oil, if you don't have any brakes, you don't need oil. As Atanasio said, oil is a very nice tool, but you need to learn how to use, and why you use, because sometimes it's toxic and we can make so much problems with oil. And then if you don't use oil. Oil, it's beautiful, but I think if you can use air or gas, it's perfect, because you're gonna have very healthy eye. But anyway, it's very nice to see all many good friends here, and congratulations, Hudson. You did a very nice section indeed, and in a very good beginning with the important talk that Mohammed Tufik just did for us. Thank you.
Thank you, Jorge Rocha. And before we end this session, would you like to comment on the next meeting tomorrow from the World Retina Congress? You could talk about it.
Yes, tomorrow gonna be a great section. Gonna be Retina and Bravis, two big societies, and we have so many good people that gonna present cases like this here, and have the comments of Koros. He's well known everywhere because he's the leader of the retinols. And I'd like to invite everyone to join us tomorrow. That's gonna be really nice. Be just 1 hour, and I think everybody gonna enjoy it. See you tomorrow, everyone.
See you tomorrow. Mohammed Tawfiq, do you want to say the last words to close the session? Our keynote speaker that showed us such interesting cases and such a reality that, I couldn't imagine how these things are good for people. And congratulations you again, and for your good work. I think you did something from the heart. Thanks a lot. Please close the session.
And I just need to thank you, and thank you all for giving me the chance to highlighting this situations and what's happening there. And I hope that then when we are meeting next episode, everything is going well, and what the situation we are facing is gone. And please pray for the people that staying in Gaza to be safe soon as much as they can. Yeah. See you soon.
See you soon. Thanks a lot. See you, Atanasio. Yeah. My friend.
Bye-bye. Have to go to... It's,
Thank you.
Thank
you very much for your presentation. Thank you.
Have a good Saturday.
Yes.
Thank you. Thank you, Marcelo.
Bye, everyone.
Yes. Bye.
Bye-bye. Nice talking to you. Thank you. Thank you for everything. Thank you, Nakamura Hudson. You're doing a great job. I don't know if you know what you're doing, but you're doing a great job. And also, I
do a job with you guys, because you are, my friends, and you are the guys. So we don't do anything alone. So honor am I to be here.
Well, it's nice to be under Waichi Lam, our professor, that is correcting us and guide us all the time. It's an incredible person who always guides us through the right path, and we have to keep it safe. Thank you very much for everything.
Thanks
enjoy
a lot.
The next of the summer, and enjoy Vancouver World Meeting. It's going to be great. Thank you very much.
Thank you. Yeah, sorry you weren't able to join, but you enjoy your family holiday.
When I say such thing about companies, you expect to have a reaction on that.
Yeah.
Let's watch Olympics. I'm going for I'm going for Hong Kong to win. Okay, Dr. Lam. So let's watch it.
Yeah. Very good.
Bye-bye, my friends.
Bye-bye. Enjoy the nice summer weather, Thanasis.
Bye, Thanasis.
Yeah, and I hope I see you in Halkidiki next year.
Yeah, look forward to it. It's wonderful weather.
Yeah, wonderful view and wonderful weather.
You've been there,
Yes, I've been there, Thanasis. Correct. Thank you for that. Had a wonderful time.
Next year, it's going to be first week of July again. So try
Right.
to get together, okay?
Sure.
See you.
Yeah, sounds
Bye-bye.
good. Right, bye-bye.
Bye. Bye, Hudson.
Bye-bye, Natarajan. See you in
Yes.
India next year. You know, Dr. Sethi invited me to be there in the All India Ophthalmological Society. I already confirmed, so I'll be around
Yes.
you, and I should be visiting you.
I hope you can go through Mumbai.
I will.
Okay. Okay.
I should. I want to
Yes.
visit
Yes.
you.
Yes, definitely.
Bye-bye.